Welcome to the Scientific Sense podcast, where we explore emerging ideas from science, policy, economics, and technology. My name is Gill Eapen. We talk with world's leading academics and experts about their recent research or general areas of topical interest. Scientific Sense is an unstructured conversation with no agenda or preparation. We cover a wide variety of domains where new discoveries are made and new technologies are developed on a daily basis. We are most interested in how new ideas affect society and help educate the world how to pursue a rewarding and enjoyable life rooted in science, logic, and information. We seek knowledge without boundaries or constraints and provide unedited content of conversations with researchers and leaders who love what they do. A companion blog to this podcast can be found at scientificsense.com, and this podcast is available on over a dozen platforms and directly at scientificsense.net. If you have suggestions for topics, guests, and other ideas, please send them to info@scientificsense.com, and I can be reached at gill@eapen.info. My guest today is Professor Michael Miller, who's a professor of cardiovascular medicine at the University of Maryland School of Medicine. He has authored numerous scientific papers in cardiovascular disease with a primary focus on prevention. His most recent book is Heal Your Heart. Welcome, Michael.
Thank you very much, Gil. Pleasure to be here.
So I want to start with a recent article from The Atlantic, Did COVID-19 Mess Up My Heart?, in which a patient says that she got sick 6 months ago. Now she can barely make it up the stairs. And the official name for her a new heart trouble, I guess, is postural orthostatic tachycardia syndrome, or POTS. And the condition is a puzzling dysfunction of both the heart and the nervous system, messes with how the body regulates involuntary functions, including pulse. And in the article, they say POTS is known to affect approximately 500,000 people just in the US, typically young women. But now, after COVID, previously fit and healthy women of all ages who have had COVID-19 are showing up at doctors' offices, complaining of inexplicably racing hearts. You want to talk a bit about it? And I know that we're going to get into more CVD issues as we go through it, but specifically related to POTS and what's happening in that arena.
Sure, Gil. So as it's turning out, the more we learn about COVID, the more we appreciate how unusual this virus is, how unpredictable it is, and and I'm sure we'll talk more about the various heart or cardiac manifestations.
Yeah.
But in this particular case, this is highly unusual because this is an autonomic or dysautonomia. So it's an abnormal function in the autonomic nervous system that it's quite unusual. Now, we have patients that have POTS, and as you point out, in this condition, often in young women, they basically, when they're standing, there is pooling of blood in a lower portion of the body. And so blood is directed, if you will, away from the body, the brain. And the longer these individuals stand, the longer they experience lightheadedness, and there's a rapid change in pulse rate. So pulse rate will increase by about 30 to 40 beats per minute when standing for more than 10 minutes. And under normal conditions, you stand, your pulse rate might go up 5+ beats, give or take, depending, of course, how well hydrated you are, et cetera.
Yeah.
But these individuals, their pulse rate goes up dramatically, and they could experience a whole range of symptoms that include things such as dizziness, lightheadedness, fatigue, poor concentration, premature beats, and so forth. But it's so unusual because we don't see this with other viruses, and just like what we're appreciating with this virus, how unusual it is compared to the typical viruses that whether it's a flu virus or other viruses that have come along.
Yeah.
This patient falls into that group that we're calling long haulers. And what we mean by that is that there seems to be an emerging group of patients who, after they've experienced COVID, so now most people are going to recover, but there is not an unsizable proportion of the population, maybe upwards of 10, 20%, perhaps even a little more, that are developing longer term complications. Of course, we don't know how long this is going to last in this individual per se, because we do know that in some cases that after 6 months or so, they start to feel better, but others may not.
Yeah.
And so POTS represents now just one of a group of conditions that that may or may not be heart related, but appears to be chronic. And some people have, after they've been in the intensive care unit for a period of time because of COVID, have developed brain fog. And some folks refer to this as ICU psychosis, and again, taken a long time to resolve.
So what percentage, Michael, what percentage of the population that we know, COVID-infected population, become long haulers?
It's a great question, and I don't think we know enough at this point.
Okay.
I'm going to say it's probably, give or take, about 1 in 5.
1 in 5. So it's
1 in 5. Yes.
Okay.
And
so 20%. Sorry, Michael. So the 20% approximately. We know that population are showing variety of issues, right? Not just POTS. And as an aside, I came back from New York. First week, second week of New York with 103-degree temperature, and was sleeping for 2 days, and it seems to have gone away after that. I don't know if it was COVID or not, but it was quite prevalent in the tri-state area in December, January timeframe. So presumably we have a very high infection rate in this area. I mean, we brought the problem cases down, but the population is very, very highly infected, I think.
There's no question. I happened to be visiting, my daughter, whose fiance was in New Haven in graduate school, and we drove up the day that New Rochelle, the news about New Rochelle having this spread of infection. So this was in early March,
right?
And that whole area has been, as you know, was hit hard. Now, with you, in your particular case, you might have had it. You're very lucky, just 2 days of fever, because fever is the most common sign or symptom that accompanies COVID. It's seen in about close to 90% of people. And if it went away after 2 days, you're quite lucky. Anybody else that you were with that had a fever?
Just 2-3 days. Yeah.
But nobody else in your group of people that.
And then my wife had something very similar after that.
Well,
yeah.
So it's hard to know. Maybe you did have it, a very mild case.
Yeah.
We do know the one thing tricky about COVID, again, there are so many unusual characteristics, but the one thing we do know is that you can get a very mild case. Now back in March, I'm sure you probably weren't wearing a mask.
Right. Yeah. This was in January. Yeah.
Oh, January.
Yeah,
right.
yeah.
So this is actually before it was widely recognized. And now we're thinking that perhaps it was in the States as early as December, as you point out.
That's right. Yeah. And so mechanistically, Michael, so this is a situation where the heart just doesn't have the capacity to pump the blood up into the brain and elsewhere?
Yeah, so here, because of this blood pooling, what tends to happen is that when you're standing, you're because of the gravity-related effects and blood going down and not coming up the way it normally does, you get that pooling of blood. And so there are changes in blood pressure, and to compensate for that mild hypotension, the pulse rate has to go up. And so, but here it's a persistent effect because of this abnormal regulation of the sympathetic nervous system.
Right.
And as a result, you have all these effects. And so the recommendations are you got to where you can this is the one case where we recommend increase in salt intake, for example. And there are medications, Metadrin, for example, to raise blood pressure, and support stockings are quite important as well. In some of the patients that we see that experience this, that obviously was not COVID related, but the treatment paradigm would be the same.
Will they get out of it completely? Is it it's treatable, but is it really curable?
A lot of our patients, it is not curable. Some are able to live with it and do perfectly, do reasonably well, and they just have to understand their limitations.
Yeah.
So we're going to tell them, don't arise out of bed quickly. Don't do things more deliberately than you would have ordinarily done or would have done before you experienced this.
Right. Yeah. So there's a paper. This is, I think, your colleagues from Johns Hopkins. The Takotsubo Syndrome in the setting of COVID-19. And the paper talks about the 58-year-old woman was admitted with symptoms of COVID, subsequently developed mixed shock, and an echocardiogram showed findings typical of stress or Takotsubo cardiomyopathy. And over the next few days, her left ventricular function improved, supporting reversibility of acute stress cardiomyopathy. So this is more of an acute issue. Again, seems like generated by a COVID infection, right?
Yeah, so this is interesting because there have been a few cases that have now been reported. I believe the Hopkins case was the first.
Yeah.
And the way we understand the so-called broken heart, it's known as Takatsubo cardiomyopathy because the original description was in Japan. And Takatsubo is named for a Japanese octopus fishing trap.
Oh.
So, and what happens is there's an unusual pattern of contraction of the heart, and so what happens is there's a bulging, a balloon-like shape during ventricular contraction, and the basis for Takotsubo is due to an outpouring of catecholamines like adrenaline or epinephrine that basically stuns the heart. And the classic description was in relationship to severe emotional distress. So an unexpected death of a loved one. And so we believe that Takotsubo here may, in this particular case, the patient did have evidence of having COVID, but there have been other cases of Takotsubo that have been now reported, even in the absence of overt COVID positivity, but based upon severe stress that they've experienced. That could be personal stress, financial hardship, a death of a loved one again, because we've lost so many people in this pandemic. So in either event, we would place Takotsubo cardiomyopathy as one of the potential complications of COVID, even if it's not direct, certainly as an indirect potential problem.
Yeah, I have heard of diabetic cardiomyopathy. That is again a shock, essentially a shock to the heart that it just cannot deal with, right?
Yes.
And so when you have COVID, and let's say you have a severe case, one of the complications here is that the typical intervention you might envision for something like this has to be mediated in the presence of COVID, I would imagine.
Yeah. Yes. So what happens is, so I'll tell you the good news and the not so good news. I mean, from the standpoint, since I attend in coronary care unit in our hospital system, and it's not only us at Maryland, it's throughout the country. We have noticed fewer hospitalizations for patients presenting with acute myocardial infarction or heart attacks. Probably we're down, I'm going to say we're certainly down by at least 50% back several months ago. We might be down now about 30%, but still quite down compared to what we see. And so in one sense, what's happening is that I think a lot of patients may have, that didn't have COVID, may have had a fair amount of trepidation to come to the hospital due to the fear of getting COVID. And so what may have happened to a number of these patients is that they had a heart attack at home, and then they came to the hospital subsequently because they had to, because they now have developed heart failure.
Yeah.
And some of the post-myocardial infarction related issues. So we have not seen as many acute heart attacks, but when putting this into perspective, patients that have COVID, while they may not get the traditional so-called type 1 infarction, where there's a plaque rupture, for example,
Yeah.
they may get what's called a type 2, which is due to an imbalance, an oxygen supply-demand mismatch. And that may be the reason that they're now coming in with lack of oxygen to the heart muscle and causing this secondary or type 2 infarction.
So will it be true, Michael, that it's so interesting. So you saw a drop in patients coming in, but if you look at type 1 and type 2 separately and mortality after hospital admissions, has the type 2 and mortality gone up?
So it's very interesting because and a lot of this will be dependent upon how that patient is managed, because traditionally, so type 1 patients go to the cath lab, they go to have stent placement, et cetera.
Yeah.
But in the type 2s, we usually don't intervene in that manner. What we try to do is treat the underlying comorbidity. So in this particular case, many of them have bilateral pneumonia, which is characteristic of COVID. And so you have to improve their oxygenation. If they're being ventilated, they may go on steroid therapy. So you want to try to treat them from that standpoint. And what we're appreciating now is something also very interesting in the COVID era. Because in a traditional heart attack, even when it's a type 1 or a traditional type 2, what happens is the cardiac enzymes, notably troponin levels, will go up and then they will come down. But in some of our patients who have had severe cases of COVID, one of the more adverse prognostic signs or measurements is a continued elevation in troponin. So that's just, again, but coincident with a highly inflammatory process.
Yeah.
So not only is troponin elevation remaining quite high for a good period of time, but so are other biomarkers of inflammation, traditionally CRP and a host of other biomarkers that you may measure. And some of these individuals are developing with this full-blown inflammation what we often refer to as a cytokine storm. What they're also getting is a myocarditis.
Yeah.
And that appears, so you can get myocarditis as part of the acute picture, or as you may have noted earlier, part of now it's becoming a pattern that we're seeing in long haulers. So in addition to POTS, you can place myocarditis into that group. And we're seeing that, and it's been reported in a number of college athletes and some ball players that have, one ball player that had to sit out the baseball season because of myocarditis. And it appears to be more, again, a long, more chronic condition. Some individuals that even may have been relatively healthy beforehand.
Yeah, I mean, this is two things I want to get your insights on. One is there's a lot of political spin around miscategorization of deaths, and it sometimes is nearly impossible to measure what the foundational cause was, right? So you may have comorbid conditions, and you may have gotten COVID, you may not have. And so what is your sense that, the measurements we are taking, we have, I don't know, 6 million infections, 200,000 deaths across the country, according to the CDC. What is your sense of those numbers? Are they underestimated, overestimated? What do you think?
Well, I think we're probably doing a better job in these numbers than other countries.
Yeah.
So, if we go back to China, the number of deaths there, I believe, was probably to some degree underreported.
Mm.
Other countries like Russia probably have some degree of underreporting. Now, there might also be some degree of underreporting here as well, depending upon how, because some patients may not have been COVID tested
Yeah.
and coming in acutely and may have died a sudden death and may have not been categorized as having a COVID-related illness. And especially if we're saying a lot of folks are not going to the hospital because of fear of COVID,
Mm.
and then happen to have some of these illnesses that come about, and by the time they get to the hospital, they're pronounced by the time they get to the hospital, we may be underestimating some of these cases.
Yeah, I was a little puzzled by, if you look at case mortality in countries like India, it's about half of what we have in the U.S. Now that could be related to the not being reported properly, as you said. But there were also some hypotheses around the BCG vaccination, some other type of things that were going on in developing countries that might be protective. Did you see any evidence of that at all?
Well, I mean, that brings up a good point, and especially in Asian countries,
Yeah.
whether it's Japan, Korea, and so forth, where those numbers are much lower. So, case fatality rates are lower in general, and then you could maybe subscribe to the idea, well, there's much better use of social distancing and masking and so forth that may have accounted for that. The BCG certainly is plausible.
Yeah.
So I think that may account for differences between our country and their country. I do think, like countries like Russia, it's just hard. I was following coronavirus worldwide daily for several months,
Yeah.
and Russia never reported more. The death rate was never more than 200. Never got to 200.
Right.
Never. It was always in 100 or below level.
Yeah.
So something just didn't jive with what we're seeing here in the States.
Yeah. And then there is a viral load issue too. So it goes to masking. So people talk about masks as sort of a binary thing, but it's also because I think let me ask you that the viral load that you are getting is correlated with the severity of the infection, right?
That is correct.
And so, wouldn't the mask then reduce viral load? I mean, it's not a binary thing. I mean, it is beneficial whatever way that you look at it.
Yeah, there's no question that the viral load is an important contributor to how sick you will get. So, a large viral load, even in an otherwise healthy person, can cause significant illness, and I think that's really important. And conversely, a small viral load may not cause significant illness in a person who you might think you might be super concerned about. So that is why it's even been recommended that if two people in the same family are ill, they should still try to stay away from each other in order to reduce basically sharing their viral loads together. So I think that we have, obviously, in our country, it's quite divided. As you know, there's still rallies that have been ongoing. There's very interesting to see the understanding, because some folks who were interviewed at a recent indoor rally for President Trump said, and I quote, "We would not come to a rally if we were sick. And since we are at the rally, that means that we don't have the virus."
Right.
So it's really the understanding that this virus is like no other, in that it could spread among those individuals that are asymptomatic, and we have these so-called super spreaders.
Yeah.
that infect multiple people, and it has to be the right setting. So we saw this in Seattle. There was a choir practice back in March where I guess one person had it and infected over 50 people. We also saw it recently at a wedding in Maine. Now, this was in an area in Maine where there was nobody that had known there was a COVID case. But in the wedding, there was a person who was asymptomatic and passed it on to, I guess, another 50 or so people. And about 7 people died, and it's spreading like wildfire in those regions. So I think that what we appreciate is that if you this is it's so basic. It's so basic that we knew about it 100 years ago.
Right. Yeah.
In the Spanish flu epidemic or pandemic in 1917, 1918, they knew back then that if you're wearing a mask and you're socially distancing, the likelihood is extremely low of getting the virus. And if you do happen to get the virus, then it's more likely to be much less complicated from the standpoint of hopefully not requiring hospitalization and so forth.
Yeah. I was, having a thought experiment. We don't know if there are multiple strains of the same virus in circulation, right? It could be potentially.
Correct. Yeah.
And if you look at the overall population, the virus needs the host to be alive so that the host can transmit to others. And so if you look at it seems to be deadly to those who are not mobile and not transmitting, and it seems to be very mild to those who are moving around, the super spreaders, and ready to transmit to anybody.
But and you can listen to some of my colleagues. So my colleagues in the medical profession, all of us health professionals, know how important it is to wear masks. I mean, there's no question. Bob Redfield, head of the CDC, is a colleague of mine. He was at University of Maryland before coming to the CDC. Tony Fauci, Phil Pizzo at Stanford. I mean, all of these guys, we all the same mindset. If you wear a mask and you're standing 6 feet apart from someone, the likelihood of getting this virus, both of you wear a mask, is extremely low. Yeah. And it's only really when you're especially if you're in enclosed quarters and not following these rules, you could run into concerns. And I tell my kids, would you go into an enclosed area if you knew there was a poison that you couldn't detect, like carbon monoxide?
Yeah.
Would you go there? Would you take that chance? Of course, my son said, no, I'd wear a mask.
Right. Yeah, exactly. It's very analogous, right? It's just that it's not positioned that way. And obviously there's a lot of confusion, as you know, in the airwaves. And so for the public to internalize that the real risk of what is being done has become almost impossible.
Yes. It's become when you're getting mixed messages, it is very difficult, except, again, we keep coming back to two words that I learned many years ago from my grandfather, and it's common sense.
Yeah, when in doubt, that never fails. I want to touch on another article, Michael. So this is a JAMA article, Myocarditis as a chronic effect. They have a prospective observational cohort study of 100 patients, and there's a lot of data in this. Do you want to sort of summarize what they found there?
Yeah, so then this gets again to that whole issue we've been talking about of this so-called a cytokine storm, and the trick about this illness is that it invades. So you're invading not only cells through the ACE2 receptor, that it's kind of a docking station, so that the spike protein could then get into the cells and then uh, allow for a viral replication. And then, of course, you have to, on top of that, we have our own immunity, both innate and acquired immunity, to kind of fight that.
Yeah.
But this virus likes to wreak havoc on our vasculature. So it's not only in muscle, but it's in the endothelium, or muscle cells, I should say, respiratory cells. It's in the vascular endothelium.
Mm.
So we can get a significant inflammation in the vessel wall. So you can get not only inflammation of muscle, you get inflammation of the vasculature. So you can get myocarditis, vasculitis, enhanced coagulation, because once you invade the endothelium and the endothelial function is abnormal, then there is release of basically a number of chemicals that can lead to a platelet coagulation or platelet clumping and coagulation, and that is a problem that we're seeing with this virus that we haven't seen with others, in the sense that patients are developing early clots, and you could check D-dimer early on. That's been an ongoing issue, and in effect, what then happens is you have to treat the patient with anticoagulant therapy to try, which was not done early on. Patients were having severe clotting issues and pulmonary emboli, and a whole host of complicating factors that in many cases led to prolonged hospitalization or death. And so one of the issues here is that this virus, like no other, could wreak havoc in so many different ways that you really have to keep your guard up at all times. And that will parlay even after we get a vaccine. I'm sure we might cover this.
Yeah.
But a vaccine in of itself is not going to do the trick, at least not in the early stages.
Yeah, and as you know, the FDA target that they announced was a 50% efficacy for the vaccine. And I think the typical flu vaccines we get every year is more like 65, 70%. And so, 50%, I don't know exactly what that is going to do, but that's the target.
Well, yeah, I mean, so 50% means obviously there's a lot of room for individuals. Even if you get up to 75%, then we're going to say 1 in 4 will have ineffective vaccination.
Yeah.
In which case that person is susceptible to developing that, and if he or she is not protected by wearing their mask and socially distancing, it's going to be a problem for a period of time. Now, how long is that period of time? So, because if you're looking at developing at least getting 2/3, if not 3/4 of the population vaccinated to induce this so-called herd immunity, it's going to take some time, because, again, it's not a one-shot deal here, right? Some of these vaccine makers need two shots,
right,
about a month apart, and then you got to give time for the antibody response, which is another, give or take, 2-3 weeks. So you're looking at, even if the vaccine is approved by late October, early November, which I think most of us don't believe that'll happen, but even if it does happen, then you're still looking at the early part of next year, first and second quarter of next year, if not the third quarter, to get a substantial portion of the population adequately protected. Yeah,
and in this country and probably around the world as well, we have a very large cohort of anti-vaccine people. And I think in the US, it's about 1/3 of the country. And so even if you get a vaccine that is 2/3 efficacious and 1/3 of the country refuses to take it, there is no way we can get to herd immunity anywhere close to the 2/3 mark that it requires, right?
And Gil, and now take that, what you just said, which is absolutely concerning, but now take the fact that in these vaccine trials, we are not sufficiently testing groups of people such as minority groups, underrepresented groups. Yeah. And we're also not testing older people, the people that are viewed at high risk, right? People of color, number one, and older individuals.
Right.
That over the age of 65, they're just not being tested in adequate numbers. And so if a vaccine is approved and we haven't sufficiently tested these high-risk groups,
Right.
will the FDA, can the FDA really approve the use of vaccination in those particular populations?
Yeah, I remember a lot of excitement about a phase 1 trial, which, as you know, is healthy males under 40. And 8 of them developed antibodies in that phase 1 trial. Uh, and and people said, oh, that means that the vaccine is just about to come to fruition. It's really difficult to accelerate these processes, right? There are some inherent limitations. It needs to be very population, as you say, the population has to be represented before we can really make a conclusion as to, it can be provided to the entire population.
But in truth, Gail, in all fairness, I mean,
Yeah.
this whole process has definitely gone at very high speeds.
That's true.
We've never seen anything quite like this. So that of course is a positive. But again, it's negated by or I guess it's in part what we discussed about the fact that a lot of people are anti-masking, don't want to get vaccinated, et cetera. So it's going to be a problem for the foreseeable future.
Yeah. So in this study, they say that we demonstrate cardiac involvement in 78 patients. There were 100 patients in the study, so 78%, and ongoing myocardial inflammation in 60% with recent COVID-19 illness, independent of pre-existing condition severity and overall course of acute illness. And so these are fairly high numbers, right?
They're very high numbers, and again, a lot of, as we pointed out, some of these individuals are young, otherwise athletic,
Yeah,
and without pre-existing care. So I think a key thing to realize is that anybody can get the virus. So when you're talking about people that are at high risk, older people that have risk factors, it's not getting the virus. It's some of the complications of the virus. But these young people who got the virus develop these severe complications.
Yeah.
That is more chronic, and that is why this virus is so problematic.
Yeah, and it's interesting that we don't really talk about a disease burden, partly because we don't really have the data yet. We have only 4 or 5 months of data. It is the case, I believe, in the Spanish flu, 1918, 1919, about 1 million people that survived it 10 years later showed Parkinson's disease. There are sufficient indications here that this has some effect on the nervous system, loss of smell, some sort of early indications. And so we haven't even started to really think about what the long-term cost of this is going to be, right? I hear a lot of young people saying, yeah, let me just get it and be done with it. Two problems there. One is the long-term effects that we don't even know. The other is there is, I think, also indication that reinfection is quite possible, right?
Yes, and that's been reported. The reinfection has been reported. It's uncommon, but it has been reported. But I agree with you. I'd be concerned about potential neurodegenerative damage over a long period of time that we just don't appreciate at this time. So we know that it appears that the virus appears at least to not only get into the myocardium, but to get into nerves, to get into the nervous system. So it's problematic.
Do we know anything about sort of the reactivation potential here? Like chickenpox or something, it is still resident but inactive, and then at some point shows up again.
Yeah, so great question. I just don't think we have that information yet at this time, because again, reinfection rates seem to be relatively low, and they seem to be seem to occur in those individuals that probably had a milder case.
Yeah.
So on the one hand, if you have a milder case, you're more likely, hopefully, not to get some of these effects. But again, it's so unpredictable. because that patient who developed POTS syndrome looked like was making a recovery and then developed it subsequently.
Right.
Then that person did not require hospitalization.
Yeah. I mean, as you know, you're the expert at this. Once you have some sort of a cardio issue or cardio event, it's really difficult to get back to where you started, right? So that is why, one of your focus areas is really prevention. Prevention is probably 10 times more important than treatment.
Yeah, I mean, we could let's talk about prevention. So,
Yeah.
on the one hand, now the good news is about stress cardiomyopathy. If Takatsubo often does recover, not always, but there's a pretty good chance of recovery to normal or near normal. So, if this was an acute event, an outpouring, and you support that patient, get him or her through that acute phase. Then towards the end of hospitalization, and even in this particular case, was reported heart left ventricular function does recover to a good extent. But in other cases of myocarditis, so different than Takotsubo, but myocarditis in a pretty sizable proportion of patients, they may have long-lasting effects. Now, again, it's too early to tell how many of our patients will recover. Usually at least 50% will, but again, too early to tell here. But what can we do? I mean, I guess the big question is, what could we do? Talk to Tony Fauci. What does he do? So what Tony does do, which is interesting, is he takes vitamin D.
Yeah.
I think he takes vitamin D and vitamin C. And there have actually been some papers supporting the notion, small-scale studies. But clearly, those individuals that have low levels of vitamin D will define them as somewhere below 20.
Right.
That it would be reasonable for those individuals to take a supplement of vitamin D. And how much should you take? Well, we don't know much. There's no recommendations for COVID, but NIH does recommend, if you do have low vitamin D, to consider supplementation with somewhere about 600 international units a day. If you're over the age of 70, perhaps 800 international units a day. If you have osteoporosis, or if you have some other risk factors, if you have limited sun exposure, perhaps up to about 1,000 international units a day. So the small scale studies did seem to show that individuals that had taken vitamin D tended to do a little bit better.
Yeah,
vitamin D regulates immune function. It makes sense. It modulates, can improve inflammatory response. So it would seemingly make sense to at least do that as a preventive measure.
Yeah, I have seen a few vitamin D studies, and all of them appears to indicate it's a good thing. Is there any connection, Michael? We see a higher level of people of color being affected by it. And my understanding is that a colored skin is less efficient in producing vitamin D, right?
That is correct. Melatonin, that is correct.
So I wondered if there is any connection there too. Obviously, it's a complex question because of all the comorbid issues.
No, it's a good question. I don't know the extent to which people of color have been looked at, specifically with respect to having COVID and vitamin D levels. It's a good question.
Yeah. And so, in conclusion, Michael, if you look forward, we have very little data. There is some data coming out of China that might give us a better insight into it. It looks like we have gotten better at treatment, right? Such as ventilators and things like that were tried early on, didn't seem like the right thing to do for most patients. It sounds to me. But what is your speculation? Let me ask you that way. Looking forward 6 months, 1 year, there is obviously an uncertainty around vaccines. We'll probably get something, but the odds of it being 90% efficacious is going to be quite low. So given that, where do you think we will be in 6 months to 1 year?
Well, I think we'll be in a much better place. I think we will have vaccination, even if we don't have most of the population vaccinated. I think we will be in a place where there are going to be fewer infections because of I'm guessing that perhaps in 6 months from now, at least 20 to 30% of the population will have some degree of vaccination. So I think that's going to help. Again, I think if we have the coordinated effort of realizing that even after you're vaccinated, at least for now, you still need to socially distance.
Yeah.
That's key. You still need to wear masks. If I were to recommend a mask that is now readily, because back in March we didn't have a lot of this PPE, a lot of this personal equipment, but we do now.
Yeah.
So you could even go, I went on Amazon before, you could even get a level 3 mask, which is a surgical mask. So you could readily purchase that. Surgical mask would be protective when you're indoors.
Yeah.
And that would be a recommendation to get a good, high quality mask that you could wear. And so I think that's going to help a good deal. I think, as you point out, some of the medications that are being used right now, remdesivir is being used. We talked about some steroids that can prevent some of the dire complications. So getting patients that are ill, getting to them early, that's also key, but treating them. Now, it's been, one of the disappointments has been the fact that convalescent plasma has not worked.
Right.
And but interestingly, I'm not sure why they were not doing convalescent serum, because there's a difference between plasma and serum, by the way. So plasma contains fibrinogen and other clotting factors. So it's not clear to me why you would give convalescent plasma to someone who you're concerned about coagulation or procoagulation, as opposed to convalescent sera, which doesn't have those coagulation factors. So perhaps some ongoing studies that might look at convalescent sera, maybe use that in earlier stage, might show something else.
Is that scalable though, Michael? Even if we find it to be effective, is it scalable?
It might be to a small extent.
Yeah. Okay.
It's probably not going to be to the level as where, if we're considering antivirals that are being tested now, other antivirals, that might work in the future. So I think some of those might come along, oral medications in combination that are being tested right now, oral antivirals that are beyond remdesivir that are being looked at.
Yeah, I saw, just very quickly, I saw a drop in case fatality in the US as the disease progressed. And I wondered if it is a numerator effect or a denominator effect. Is it because people getting infected are younger? Or is it because we have figured out how to treat this a lot better, or maybe both? I
think it's both. Clearly, the fact that we are, I think, able to treat these patients a bit better. We're not as overloaded as we were, especially in the Northeast, when New York and New Jersey were being bombarded with so many cases, and it just didn't have the bandwidth to really effectively take care of all these individuals. And then, of course, it went to Arizona and Florida and Texas. But I think things are under a bit better control, identifying patients a bit earlier and starting some of these therapies a bit earlier would be helpful. And as you said, a lot of the people that are getting infected now are younger people. And of course, they have a much more favorable prognosis, much less likely to need hospitalization.
Right. Yeah, excellent. Yeah, this has been great, Michael. Yeah, thanks so much for spending time with me. And good luck with this research.
Thank you very much, Gil. Pleasure.
Thank you. Bye.